Good afternoon and welcome again to Cancer Center Grand Rounds. Today's forum is a special forum. Today we celebrate a special lectureship, the Iris Fisher Memorial Lectureship, which was endowed by our esteemed colleague and faculty member David Fisher, who honored the legacy of his wife Iris with this fellowship. And over the past 16 years since its inception in 1999, we've had a series of outstanding visiting faculty who have lectured on a variety of critically important topics in cancer research and clinical care. And we're very fortunate to have another outstanding lecturer, Dr. Francesca Gany. Dr. Gany actually has roots here at Yale. She received her bachelor's degree from Yale University, her medical degree from Mount Sinai School of Medicine, and then having her training at New York University, both in terms of her training in internal medicine and her master's of science in health policy. Today, she is the founding chief of Immigrant Health and Cancer Disparities Center at Memorial Sloan Kettering. She has served as principal investigator on a number of pioneering immigrant health studies and programs in the areas of cardiovascular disease, cancer treatment, adherence, quality of life, language access, among others. She has led a series of important studies examining underserved populations. And her topic today is Aspire, Adopting Socioeconomic and Psychosocial Interventions to Promote Equity. Dr. Gany, thank you.
Thank you. Welcome, and it's great to be here, and I've had the opportunity to meet with a number of people, had some really great discussions, and I hope that we can work together moving forward. Oops, got it. I got it.
It's actually, I didn't know that button.
So this is going to be a little bit multimedia, so I'll be switching back and forth a little. Oops. Okay. I wanted to start by actually talking a little bit about my trajectory in this area, to give a little bit of an idea of where I'm coming from and how this work has evolved. So back when I was doing my residency at Bellevue at NYU, there was a new migration of Senegalese immigrants who came to New York. And this was a very small immigrant group at the time, and it was the first time that any of us had really seen many community members who had come from Senegal. And I was working the primary care clinic at the time, but these guys were working long hours, at that time mostly peddling watches and other goods on the street, and they were starting to fall ill. And they came into Bellevue through the emergency room because the emergency room was open when they weren't working, and it seemed like an easy access point into the healthcare system. And so they would see the provider in the emergency room complaining of abdominal pain radiating around their waist to their backs. And one after another of these guys had the same set of symptoms. And the ER would see them, they would be seemingly well, and they would order a multi-million-dollar workup on them. Upper GI series, stools, at that time, barium enema, ultrasound, everything they could think of to try to get to the bottom of this, especially because these guys did not speak English, and they had very little ease of communication with them. They would then send them up to the primary care clinic, and they spoke Wolof, but they were from a Francophone country, so I spoke French. They would send them all up to my clinic. So I saw 40 of these men in a row, and they came in with the same set of symptoms, yet their workups were completely negative. But their feelings of distress, their pain persisted. So I realized something else must be going on with them. So I enlisted the aid of an anthropologist who had worked in West Africa, and we went out into the community and we started to ask the community members what they thought might be going on, and we asked the patients what they thought might be going on. And we learned that in Senegal there's something called TOI, which is essentially a Senegalese somatization syndrome, which happens when you're removed from your family and friends, which is what happened with this migrant population, when you're working very, very hard, which these guys were doing, and when you're feeling a sense of loss. So that described what was going on with the community. So as we got to know about this, we found out that in Senegal, this is treated with something called kel, which is a gelatinous substance which comes from a tree, by talk therapy with a healer, and by gathering the community around to support those who were ill. So because we had been out in the community doing all of this work with the community members, we were able to bring the community together as a source of support for those who were ill. We suggested that they use tri-notch gelatin. It was a culturally familiar remedy, the gelatinous substance. And also we contacted the healers in Senegal, and when we were in clinic with the Senegalese, they did some talk therapy over the phone. And one by one, these guys got better. They were able to start working again, and the community grew and grew, and we got very engaged in caring for the community and understanding their language of distress. And I realized that if this was what was going on with this one small immigrant community that we could easily get our arms around, what was happening with all of the other communities in New York, the larger immigrant communities, who had barriers to accessing a system that understood their needs, their beliefs, and where they were coming from. So that started us on a path of bringing folks together who were working with immigrant communities and trying to really figure out what the access barriers were and getting to know the community organizations. The TB epidemic then broke. And because we had this infrastructure of community groups that were working in concert with the healthcare system, we were able to quickly roll up our sleeves and to identify ways to work with the community to start to diagnose folks who might have TB, and also to help them get treatment and do case management into cure. And this was such an effective partnership with community-based organizations, the Department of Health, the healthcare system, and the providers, that we realized that this was a really great platform to address other disparities that were out there in the community. And that led us into doing this kind of work around cancer and cancer risk reduction, screening, bringing people into care, and then working with them through to the treatment completion and into survivorship. And that's how what was then called the Center for Immigrant Health and is now the Immigrant Health and Cancer Disparities Center was born. And that's really been the approach that has followed us through our work. So why is this especially important today, that we have a particular way that a model that we apply to immigrant communities? Well, the demographics of the U.S. certainly show increasing numbers of immigrants, although in the last few months that has changed a bit. 13.1% of the population in the U.S. is foreign-born. In Connecticut, it's almost 14% of the population, and where we work in New York City, it's 38% of the population is foreign-born. So we really need to know, understand our communities, reach them, and work with them to ensure the best outcomes possible. In the U.S., this is becoming an issue really in every state. When we first started out, there were some key magnet states that immigrants would go to, but now almost every state in the U.S. is seeing growing numbers of immigrants and really needs to understand the populations that we're working with and the best ways to reach people. So at the Immigrant Health and Cancer Disparities Center, we have a mission to bridge immigrants and other underserved populations with a receptive healthcare system to help facilitate equitable outcomes. And we use an integrated mixed method approach that at its core is community engaged. We don't do anything without working with a community advisory board, community-based organizations, and members of the communities that we're serving. And we have an approach that's very translational. So when we develop a research project, we're thinking, okay, what's this going to translate into in terms of patient care and also in terms of policy changes? And we really gather our data with that in mind to make sure that what we do is very practical in the end and really impacts outcomes. And we have three arms to our approach: research, service delivery, and training and education, and these really go hand in hand and inform each other. We have three ways that we sort of parse our projects. So one is a really large focus, and that's really what I'm going to focus in on today, on addressing socioeconomic determinants of cancer disparities. Immigration and immigration status issues, legal issues, economics, language and culture, occupation, other socioeconomic aspects of people's lives that impact upon their health, their treatment, and their outcomes. And then we think of disparities by community. So we have several community-focused projects. We have a South Asian health initiative, we have a Latino health initiative, an Arab health initiative, Chinese health initiative, and a West African health initiative. And the reason why we do it by community is that really key to our work is working very closely with the community-based organizations that are embedded in the community, that understand the language of the community and the culture, that are trusted by the community, and through whom we can really develop interventions that the community embraces and that carries them forth to better health outcomes. And then by disease site. So we have programs that focus on breast cancer, colorectal cancer, and also shared cancer and cardiovascular disease risk, such as obesity and lifestyle issues. Our initiatives range from very local to our surrounding community, to all of New York and its boroughs, to more national initiatives. So we have a number of initiatives which have started local but have grown to be national, and we're also working in the global arena in places where our immigrants come from, because there's a lot of circular migration. Collaborations and partnerships are really key to our work. We collaborate with the community. We partner really closely with advocacy groups. That's that policy level that I was talking about, and service delivery groups across institutions, and with our city hospital system, Health and Hospitals, New York City Health and Hospitals, and with the federally qualified health centers that serve the communities that we work with. So I mentioned that I'm going to focus on socioeconomic determinants of health. And the first one I'd like to talk about is immigration status and the legal issues that either come from people's immigration status or people's perceptions of what they can and cannot do in terms of access to the healthcare system based on their immigration status. So we work a lot in the community and really work with community-based organizations who can inform their community members that it's safe to access health care, that if you access health care, it's not going to make you a public charge which would influence your immigration status in the future, and that the healthcare system in New York and other city agencies are mandated to not turn information over to immigration. So even with all of that, in the last few months, we've seen a tremendous chilling effect of some of the policies that have been put into place or attempted to have been put into place. And we're seeing a very big drop-off in appointment keeping, actually, at the cancer centers and the cancer clinics, because people are afraid to come in for care. So one of the things we've had to do lately is really redouble our efforts with our community partners to let the community know that it's still safe, but always to be following what's going on at the federal level and locally, so that we don't misinform people, but that we could bring people into care and continue for them to have the trust in the healthcare system. The next thing I wanted to focus on is language and culture and linguistic and cultural responsiveness. And so why is this so important? It really overarches all of the elements of our work. Limited English proficiency is growing in the U.S., and it really affects how people understand their health and how people interact with the healthcare system. 9% of the total U.S. population is limited English proficient. That's 50% of the foreign-born population in the U.S. In Connecticut, 5.2% of the population is limited English proficient. That's a quarter of the foreign-born population. In New York City, fully a quarter of the population is limited English proficient. That's about half of our foreign-born population. So it's really important that our services really reflect the languages of the community, and that we have very good infrastructure in place, really good systems in place to bridge our patients, to bridge our community members with either providers who speak the same language, although we don't yet have enough providers who do, so then with really good interpretation and translation services so people could get equal care and also equal access to research, to clinical trials, to any studies that we have that other people can participate in who speak English. So we have a language initiatives program which supports this kind of work. and not only supports the infrastructure building, but also does research in terms of the language barrier and its impact on health outcomes. I'm just going to give you a little bit of a taste for why we started this program. Wrong. That's not good. Hello. Let's try this in full size. No. Okay, I've now hit every button here.
Why don't you close out and start again?
Yeah, that's what I'm doing.
You want nachos, right?
It's nachos, yes. Thanks. Okay, so confronted with this, and the fact that oftentimes an ad hoc interpreter is brought into the room. In this case, it was a security guard. Here was a woman who had actually fled from her country and was very nervous with it turned out afterwards, we learned, with a security guard who was there. And the doctor, who was limited Spanish proficient, and couldn't really communicate with her, but was trying to establish some rapport with her. Although he was well-intentioned, it was misguided, and she didn't understand really what he was trying to say. And this happens over and over again, unfortunately. And it's unclear if this woman would have gone for the mammogram, understood why she needed the mammogram. She knew something was dangerous, which could have been quite scary to her. So we saw this happening over and over again and realized that we needed to really develop an infrastructure that would help prevent something like this. So we, sorry, let me just get this back to the right place. Okay, so we started to study the impact of the language barrier on outcomes. We did, looked at a nested cohort of patients who were in the cancer clinic, And we found that through surveys and chart reviews and interviewing the patients, that 14% of the patients had an incorrect knowledge of their cancer diagnosis, predominantly limited English proficient patients. The biggest switch was between cervical and ovarian cancer. And what we found was that a lot of times these patients, because of the language barrier, were having their children look things up on the internet for them. And their children, if they had cervical cancer, were instead searching for ovarian cancer and finding out everything they found out about ovarian cancer. And it was actually false. Their family member had cervical cancer. So given that we were finding such terrible impediments to proper understanding of cancer diagnosis, we knew we had to act quickly, and we needed to look more closely at what was going on. So we did a study to look at errors across the clinical encounter, and we looked at scripted breast cancer encounters. And we looked at it, we used an error analysis tool to look at what was going on in the clinical encounter with ad hoc interpreters and with trained interpreters. And we found that 27% of errors made by untrained interpreters were of moderate or greater clinical significance versus 8.5% of errors made by trained interpreters. The vocabulary precision rate was much lower for the untrained interpreters versus the trained interpreters. By the way, it still wasn't good enough for the trained interpreters. And here are some of the errors that were made. The doctor said the results were positive, which means that you carry the gene that puts you at risk for developing breast cancer. The interpreter said the results were correct. The doctor said one important thing that you have going for you is the fact that the cancer has probably been caught early. The interpreter said one important thing is the fact that the cancer is working quickly in your body. The doctor said the doxorubicin could hurt your heart. The interpreter said the doxorubicin can give you pain. And these are real errors from those misinterpreted encounters. So this led to a task force to address the issues of interpreting in the clinical encounter, which has really changed policy in New York State, so that now in the clinical encounter, one needs to have a qualified interpreter, which is usually interpreted as a trained interpreter with training in medical interpretation. And that interpreter is supposed to be there for all the clinical encounters as well as for any research encounters. And that interpreter can be an in-person interpreter, but it doesn't have to be. It can be a qualified over-the-telephone interpreter, which is a much more efficient way to do it. And we're now working on a technology solution that brings you UN-style interpreting, remote simultaneous medical interpreting, right into the clinical setting, so that you can have a simultaneous conversation with your patient, just as you would with a same language patient. And then it really approximates a same language interview, and that's got much lower error rates we've found in subsequent studies. So this has guided not only public policy, but it's also guided clinical policy in a lot of the institutions in New York. And our Language Initiatives program trains interpreters, it assesses them, it works on translations for studies, it provides interpreters for navigating patients through clinical trials and other studies and through care, and it works a lot on policy formulations. So this really underlies all of our work and really needs to underlie all of the work that folks do with limited English proficient patients, so that we're sure that their clinical care is well understood by the patient, that a therapeutic alliance can be formed, that there can be good decision-making partnerships, and it also underlies the research services that are provided, so that people participate in research they understand, they make informed decisions, informed consent, and so that they can participate fully throughout the course of the care. So that underlies all of the work, but today I'm going to focus on a couple of projects that we have. One is on a patient-level intervention. It's in a patient navigation program and an outgrowth of that program, which is a food security project. And it also focuses on, and I'm also going to focus on communities and how we work with the communities in New York City and across the country who are at risk for poor cancer outcomes, and then shared cardiovascular disease and cancer risk, and how we do risk factor reduction in these communities. And I'll talk about a project we have in partnership with the Mexican Consulate and our taxi network. So a very a growing issue now for all of our patients is the financial toxicity of cancer treatment. And this is especially important for underserved patients, for patients of lower socioeconomic status. Because here's a group of patients who have jobs that often don't give them time off for medical appointments. They have no sick leave. Many people are working hourly jobs, so any hour they take off is an hour of precious lost income. And whereas they might be doing okay, going along economically, just sort of at the edge, but getting by, the minute they get that cancer diagnosis and they need to come in for care and they need to come often, or they need to buy special equipment or have a special diet, it sort of pushes them off into a very, very poor financial situation. And so that's one of the things we're looking at. What is the impact of a cancer diagnosis on this group of patients, and how can we intervene to improve not only their financial situation, but the impact that has on their adherence, their appointment keeping, their quality of life, and their cancer outcomes. So in New York City safety net facilities, the baseline treatment completion among immigrant patients in the safety net facilities had only been 75% when we first started this project. And so then we did a study to look at why this was. What were people telling us that was preventing them from completing their care? And it was different in the different groups. So 59% of our Latino patients, who are also, of course, not just one group, but very diverse, reported needing assistance with financial resources to help them complete their care. 37% with food resources and 21% with transportation. So you think New York City, people could get on a subway or a bus, but transportation was a major issue for our patients. 87% of our Chinese patients reported that they needed financial assistance, 80% with food. And they said that they had a lot of missed appointments due to a misunderstanding of something simple, like when was the appointment scheduled for, and then conflicts with other appointments and language barriers. Despite all of these financial needs, less than a quarter of the patients reported ever working with a social worker. So there's a dearth of social workers at many of our safety net facilities, but also people weren't hooking them up with services, and part of that was the language barrier. So we started a project called the Integrated Cancer Care Access Network. So this is a coalition of diverse groups, the clinical groups, healthcare facilities, policy folks, faith-based organizations, community-based organizations, and a number of researchers who come together to find ways to try to increase access to care that is linguistically and culturally responsive, and to get people through treatment. And we're using the same model now for getting people into and through research studies. At the patient level, we rely on our access facilitators, who are really like souped-up patient navigators, and we have 11 participating sites where we have these access facilitators. We're doing a randomized controlled trial now, and we have found that this access facilitator intervention has increased treatment completion to 93% in some of these same safety net facilities. So they're all bilingual, the access facilitators. They address patient-provider communication, so they sort of work with the patients to activate them, to ask questions of the providers, and participate as fully as possible in their care, ask them about side effects, pain treatment, etc. They focus on treatment completion. Some of our patients had never even been told that it was necessary, important to go to every appointment, every radiation appointment, and to complete their treatment. They help them with the socioeconomic barriers to treatment completion. So they have made linkages with over 250 community-based organizations and community resources, so they can bring these socioeconomic services into the hospital and with the patients. They help them to get health insurance, childcare. Housing's a really big issue for us and our patients, so they're working with a coalition of legal services reps and housing organizations to help our patients get good housing. And then the financial toxicity of treatment. So the employment impact, talking with patients, teaching them how to talk with their employers about accommodations, medication costs, transportation, and food. And in the pediatric setting, we have a similar program going, but we see a slightly different array of needs. So financial support is huge for the pediatric families, but a really important need which was going unmet was academic services for the patients. Child education programs, housing, transportation, many of them are very similar. I mentioned food as being a really important issue, and this has really grown in terms of our understanding of the role it plays in our patients' quality of life and adherence with their cancer treatment. So we know that food insecurity or lack of access to enough nutritionally adequate food is linked with many diseases. It's linked with obesity, cancer, cardiovascular disease. And we know that the incidence of food insecurity and the prevalence is growing in the U.S. So the entire U.S. population has a 14% rate of food insecurity, and very low food security is at 6%. We know that it's higher for minorities. The Hispanic population, for instance, 22%, and very low security, 7%. So 1 in 6 of the population is food insecure. In cancer, we know that cancer patients are particularly vulnerable. Compromised nutritional status is something we really look at in our patients, frequently associated with chemotherapy and radiation, but for us and the patients we take care of, it's frequently associated with their socioeconomic status also. It can lead to impaired healing, immunosuppression, infection risk, recurrence, and certainly decreased quality of life, and we have found access to care as well. So we looked at a cohort of underserved cancer patients in New York City, over 400 people, and we found that, so it's 14% in the U.S., we found that in this cohort of patients, 56% of the patients at the safety net facilities were food insecure, and they were going days sometimes, skipping meals without food, while they were getting their chemo and while they were getting their radiation. 38% had low food security, 18% very low food security. That's 4 times New York City average, and the New York City average is way too high as it is, but this is 4 times the New York City average. And this was associated with not speaking English as your first language. You had a greater chance of being food insecure, poor healthcare access generally. It was certainly associated with people skipping treatment. And people told us they had less money to spend on food since starting their cancer treatment because of the job situation, because of the transportation needs, because of co-pays. Just of interest, given that there's a lot of swirl now around SNAP and further cutting SNAP benefits, we looked at over 1,000 of our cancer patients who were SNAP versus SNAP ineligible, and we found that cancer patients who were receiving SNAP had only slightly lower rates of food security, so 53% of those receiving SNAP versus 61% of those not receiving SNAP. Those who were receiving SNAP had the slightly lower rates of food insecurity, higher rates of food security. So 61% of those receiving SNAP were food secure versus 53% of those who weren't. So SNAP wasn't doing such a good job. And when we looked into this further, there are many people who are on SNAP now, Supplemental Nutrition Program, and many of them are getting $13 a month in benefits. So there's a lot of room for advocacy here, so keep your ears on this issue. So then, seeing how much of a need this was in our community, we did a study of emergency food resources surrounding these safety net clinics. So we looked at the top 50 zip codes for our patients, and we looked at the food pantries in the neighborhoods, because this was where people were expected to go to supplement their food. And we found that the pantries are often inaccessible. They have limited numbers of hours of operation, sometimes just 7 hours a week. And for our patients who have to come in, go to their cancer appointments, skip work, etc., this just didn't work for them. They also give them very few pickups, sometimes once a month. Many of them required a government-issued ID, not so cool for our patients who were undocumented, and that really kept them away. Limited language resources, and then it certainly didn't work for the specific needs of our patients and the cancer-related diets that they needed to be on. There were limited food choices. It didn't work with their treatment regimens, didn't work with their cultural, like what they were used to eating. And then also it was hard for them to travel because of the effects of their illness. So we developed an intervention, a medically tailored, hospital-based food pantry, in partnership with the Food Bank for New York City. We now have 7 pantries at safety net hospitals in New York City, and we have one at Memorial too. So Memorial was a little slow to come on board because they thought that their patient population didn't need the pantry. We did a survey at Memorial, and we found out that at Memorial, 18% of the patients are food insecure, which was really shocking to the folks at Memorial, and the pantry has been very widely utilized there. We provide nutrition education with the pantry services. We provide education on stretching your food dollars. And we are also working with the providers and with the staff to implement food security screening. You can do it with just 2 questions so that all patients are screened, because this was really a hidden epidemic in the clinic. And we have an online education module now for providers, which also helps link the patients with resources. We've developed a pantry software so that we can inventory what we have in the pantries and give patients more choice. And the pantry program is really growing, which is great, but also sad that there's so much need. So in 2016, we served over 550 patients, and that was the equivalent of 35,000 meals. I have to say that the executive orders in January did not only have a chilling effect on appointment keeping, but it had a chilling effect on pantry utilization, because people were afraid that this pantry was somehow associated with the government, and we've had to do a lot of education in the clinic to let them know, no, none of this information will be turned over, because they were afraid that that would lead to their deportation. So we realized the pantry is great, but it's still a pantry. It's not really giving people the opportunity to buy what they want or need for their cancer treatment. So what else could we do? So we started a voucher system that mirrors SNAP, but is different. It's much more generous than the monthly SNAP allocation that people were getting. But it's an electronic debit card that people can use at the supermarket. They can only buy food and beverages, non-alcoholic beverages with it. They can't buy anything else. They get $230, and I mentioned it's restricted to food and beverages. We look at their receipts. We see what, it's part of a study, which I'll talk about in a second. So we see what they're buying. They get nutritional counseling too. They have a choice of whatever they want to buy, but we do look at it and we review that with the patients so that we can make sure that we're at least trying to inform their food choice. And this was great for patients and made a huge difference. But we realized that sometimes for patients, it was hard for them to carry these bags home from the supermarket. We gave them all carts, so what about home grocery delivery? So we started an intervention that was a home grocery delivery intervention, and this was really added in response to their feedback. It's a weekly delivery from Fresh Direct. I wish I could say they were donating some of the food, but they are not. This is restricted to healthy products. We order it with them. Whole grains, fruits, vegetables, milk. It's really, these two, this and the voucher program is really, they're both beloved because it enables people to purchase a lot of fresh produce if they want. They get about the same amount as in the voucher, and it gets them about 5 lunches and dinner a week. So we are now doing a randomized controlled trial looking at the impact of the pantry alone, the pantry plus the vouchers, and the pantry plus home grocery delivery on treatment adherence and completion, quality of life, food security, and nutritional status. And so far we have 103 patients enrolled in this RCT in Queens, Manhattan, Brooklyn, and the Bronx. And so far we have early results from this. So it definitely improved food security across the board, the pantry, the voucher plus, and the delivery. So that's wonderful. The delivery arm had the greatest decrease in the food insecurity score. We're looking at quality of life and depression. So we saw a significant improvement in the quality of life scales. And the greatest improvement in that was in the delivery plus the pantry, and we saw a dramatic reduction in depression symptoms, with the largest reduction among the pantry and delivery arms. And in terms of treatment adherence, we're also seeing in terms of appointment adherence and in terms of treatment adherence, and the biggest impact has been for treatment adherence has been in the voucher arm, actually. So this has been a really important project. It has a lot of implications for patient care. We're seeing great increase, in adherence, in quality of life, in food security scores, and we're working with the New York City Council around the policy end, and how can we take these results and make them system-wide in a really seamless way. So even though the grocery delivery had a somewhat better outcome for the quality of life than and the PHQ-9 than the voucher system still did great, and it seems like this is what the City Council is probably going to go with, because as soon as somebody qualifies for emergency Medicaid, which makes them means they're ineligible for SNAP, but still at great socioeconomic risk, they can also qualify for the voucher, which they can then use for the duration of their treatment, the amount of time they're on Medicaid. And so that's a way to make a systems-wide approach. It also has had a big impact on clinical practice, because now in all of these facilities, we screen all of the patients for food security, and then that, of course, is impacting treatment adherence, quality of life, et cetera. So that's one example of what we've done on the patient level in the setting at the cancer center. But we also think a lot about the communities at risk and what can we do to keep them out of the cancer center and keep them cancer-free. And we look really for window of opportunities to work in the community and to provide culturally and linguistically tailored risk reduction and community-based screening. So I'm going to talk first about one program we have called the Ventanilla de Salud, the Health Windows program. That's actually a program of the Mexican government and its U.S. partners. This is a health window at 50 consulates, all the consulates the Mexican government has across the country. So the Mexican population is the largest immigrant population in the United States, and they have poorer health outcomes than a lot of other Latino populations and then the U.S. population as a whole. So in the New York City Mexican consulate, which is actually a tri-state consulate that covers Connecticut, New York, and New Jersey, the consulate sees over 400 people a day. So it's an opportunity to reach large numbers of people who are otherwise quite marginalized from the healthcare system. And at this consulate now, we've set up a health screening program. So we do a very extensive intake, asking people about their health history and their health access history. Then we screen them for BMI, we check their blood pressure, we check their hemoglobin A1C or their glucose, and we check their cholesterol. And then we check their cancer screening profiles. And then we navigate them into healthcare if they need to be navigated, either into primary care, always into primary care, but also often into cancer screening and whatever else they need. And then it's sort of, we're the primary academic partner for the consulate, so the New York City consulate acts as a lab, and we try interventions in that consulate, and then if it's effective in that consulate, we have a broader group we call the second generation VDS, where we then expand these concepts, and if it works there, then they can be expanded out to the 50 consulates. So it's a great way to do some work locally that's effective, but also bring it out to a number of additional sites. And it really helps the evidence be translated into policy, because we're working with the Mexican government that has access to all of these communities in New York. So I'm going to talk now about a food intervention again. I just talked about a food intervention at the patient level, about the Comida program. And this is a program for folks to make more healthy food choices. So at the VDS, we look a lot at this shared cancer and cardiovascular disease risk. And these are some of the demographics and health information at the VDS. So we looked at 891 people at the VDS. We found that 97% were limited English proficient, so we know that puts them at risk right away for poorer access and poorer outcomes. 76% are living below the poverty level, something else that puts them at great risk. 86% uninsured, 69%, which goes with the uninsurance rate, did not have a primary care provider. 44% obese and 44% overweight and 39% obese. So right there we see huge cardiovascular disease and cancer shared risk. 68% were never screened for colorectal cancer in the New York City site, and 72% across the national sites. Not surprising given the poor health care access. And then we saw a lot of elevated blood pressure, diabetes, not surprising. Only 36% reported doing moderate activity or more for the recommended 150 minutes per week, and 83% had never been counseled on a healthy diet and weight. So with all of that overweight and obesity, most of them thought that was fine. And part of that is cultural, like what people grew up hearing and believing, and part of that is they had never been to a doctor, and if they had been, they hadn't been told. So we gave them the good news. So we started this Comida program, which has an intervention that has multiple components. So one is these assessments that I was talking about, plus a 24-hour dietary recall. Then we use that dietary recall to either do individual counseling, and we work with nutrition students and other nutrition resources, or there's a group session as well, and we're doing a randomized control trial looking at the individual versus the group. Text messaging, this is a group that really uses its cell phone and it's their cell phones and really text messages a lot. So 96% of them use text messaging and were willing to get text messages. So we text message them 3 times a week. We've identified neighborhood food resources, really important to see what's at the community level, and grown some of them so that they had access to some higher quality food. And then we bring in the flyers, the circulars from these places, and we go over them with the individuals. And then we gave them tools like healthy eating tools, measuring cups and spoons, my plates, so they could get an idea of portion control, which was a major issue for the community members. And then we do a 3-month follow-up where we measure their BMI, their dietary behavior, their food security, because this is also a food insecure group. And so I'm going to skip to the 3-month results just for weight loss. So 40% of the participants lost between 3% and 8% of their initial body weight. They had improved control of their diabetes and hypertension, and they reported major changes in their food choices. So one of the big issues was they were eating a lot of sugar-sweetened beverages. That really decreased, and less fried food, more fruits and vegetables, and really changed the nature of their diet. So this was just a 3-month project. We know that weight loss, in order to be maintained, could be a much longer process, but we're working on strategies to continue this and then to work with the community members to measure weight loss. We've also been working with the community-based organizations that work with us and with the consulate, the Mexican Coalition, Make the Road, to train their promotoras in this approach, and they've been then taking this out into the community, and they're reporting similar success. So this was one project at the consulate, but there's so much other work for us to do there in concert with the community. So I'm going to talk about one other issue. So we know that cervical cancer, the numbers are quite great in Mexican immigrants. Not the rates necessarily, but given that we have so many Mexican immigrants, the numbers are really great. So, and we know that the Healthy People 2020 goal is 80% coverage with HPV vaccine, especially, among minority and underserved populations who are at risk. So among eligible Latinos, the vaccination rate is 35%, which is not that different from the U.S. as a whole, actually. And I mentioned that HPV cancer cases are higher. And so we know cell phone text messaging really utilized in the Mexican community. So we did, this is the work of Abraham Aragones, who's one of our faculty members, a 2-arm study with Mexican parents of HPV-eligible children to give them education as one arm versus education plus text messaging. And this was just before, when it was 3 doses of HPV vaccine. And we saw that in just the education alone group, the initial uptake of the vaccine was pretty high, 85%, second dose, 50%, but then it went down to 33% for completion. But with the text messaging intervention, there was an 88% completion. So this was really encouraging. So we have a U54 partnership between Memorial Sloan Kettering and City College of New York. And so we put this in as a full project for the U54 and expanded it, and we've seen the same results with over 250 participants. And now Abraham just got an R01 to take this out to 4 VDS sites across the country: New York, Chicago, Las Vegas, and El Paso, and to look at how this will work, given that the healthcare systems are different in each place. But certainly the education and activating the community to ask the provider for HPV vaccine is key. He's also working on a complementary study, because it has not been that the community has any notions about promiscuity, which a lot of people have said, or do not want the vaccine. In fact, vaccinations are one of the revered public health interventions in Mexico, and the Mexican community is very receptive to vaccine interventions, and that was not the issue. The issue is the providers not recommending to the community members. So here we got community members. We help them to ask the providers for the vaccine. The complementary study is working with the providers so that they offer the vaccine to all of their patients. So that's one community. The other community I want to talk about today is the taxi driving community. So New York City has a huge number of taxi drivers. We have about 150,000 taxi drivers now. 97% of them are immigrants, and they have terrible health disparities. They sit in that cab all day long, 10 to 12 hours a day, 6 to 7 days a week, sitting. To eat, they'll grab whatever. They have terrible diets. They have high rates of stress. They get stress from their passengers, stress from the Taxi and Limousine Commission, which tickets them. It's a high-stress, low-exercise job, and they have very poor healthcare access because they're driving such long hours, and they're independent contractors, so they don't have access to any institutional health insurance resources. So we did a focus group study with the taxi drivers to find out what their healthcare needs were, what their thoughts were about their health, and I think this one quote sums it up. Every disease a man can get, he can get in this cab. These guys knew that their jobs were killing them, and they wanted to do something about it. So we decided that we'd work together on some initial smaller, interventions, and then it has grown into what's the Taxi Network, which is our, a growing community-based participatory research project in this population. Of note, only 38% of the drivers were screened for colorectal cancer, despite their great risk. So our community-based participatory research group consists of the South Asian Council for Social Services, they co-direct this project with us. We have a taxi cab, a community advisory board, very diverse taxi drivers in terms of what kinds of taxis they drive, where they're from, their ages. We have the fleet owners associations and the garage networks involved, because the garages are such a wonderful place for health interventions, because the drivers go there every day to turn over their cab from the day driver to the night driver. Green cab bases too. We're working with the Taxi and Limousine Commission because they have a great communications infrastructure for the drivers. They can send messages out to the drivers. We have community-based organizations that have large taxi driver membership. One of them in the Bronx is called the Union Futa, and a number of faith-based organizations have a lot of taxi drivers. We're working with them because they go to pray, so we can reach them on a daily or a weekly basis. We're working with the New York City Department of Health and Mental Hygiene, and then we have clinical sites that are our partners, so that we can have a seamless referral structure. So the Institute for Family Health, which has a network of federally qualified health centers, and New York City Health and Hospitals, and they've been really eager to work with these guys. So one of our first studies was called Step on It. So this was to do healthcare access and CVD and cancer risk reduction. It's a case management project. So we recruited 480 taxi drivers at the holding lots at the airport, because the holding lots are also another wonderful window of opportunity. At LaGuardia, the line moves kind of quickly, so they only have a half an hour, so we'd have to do really quick health education. At Kennedy, they sit there for an hour or 2 hours waiting for their fare. So what a great place to get in there, to do screenings, health education, and to get them walking, because they can walk around the holding lot. And they're also, even though they're very independent, and that's part of why they drive, and they're independent contractors, they also have affinity groups at the holding lot where they play dominoes, they play cards, they talk about soccer, they talk about cricket, they watch the cricket matches. So it was really a way for us to find groups of people who could support each other in healthy behaviors. And one of the things we're looking at is social networks of the drivers, and how we can use those social networks to influence health. So we founded this like health camp, series of health fairs, that half of the drivers did not have a primary care provider, which goes along with half of them not having health insurance. By doing a case management program for these drivers, we were able to increase health insurance enrollment by 50%, and at least one annual visit to a primary care provider by 51%, working with these partners at the New York City Health and Hospitals Corporation. And this really helped to institutionalize the project. So now we do a lot of these health fairs, which is a way to do assessment of their health risk, their health background, and also to get some biometric data, and then to navigate them into care. And we found that in one set of health fairs that 25% of drivers had a diagnosis of hypertension, but more than half of them had an elevated blood pressure when they were screened. 39% had an elevated blood pressure, but no history of hypertension. And when I say way high blood pressure, we're talking 200 over 100, crazy scary high blood pressures that hadn't been treated and really put them at risk. And a very small sample, not surprisingly, reported being regular exercisers. We also did an assessment of their knowledge of the Affordable Care Act and helped use this to develop programs to give them access to insurance and to care. We did a taxi needs assessment where we looked specifically at exercise and also looked at their social networks, and that led to step 2, which is supporting taxi drivers to exercise through pedometers, where we're doing a pedometer intervention. We did a pilot first with South Asian drivers on pedometers, and it was successful at increasing step counts, and now we are doing it with all of our drivers. We looked at text messaging because even though they're not supposed to be using their phones, these drivers are incredibly linked to each other by cell phones and text messages. They have text messaging groups through the Viber app, and so we're working with these groups to tap into their social networks for exercise and other helpful interventions. So now we have a randomized controlled trial called Taxi Hail, Health Access Interventions for Lifestyle and Linkages. It's a 3-arm cluster randomized controlled trial done at the level of the taxi garages, and we've enrolled 30 taxi garages into the study. It's ultimately going to be 900 participants, 900 drivers, and we are looking at a health fare control as an intervention. We're looking at the health fare plus a like navigator case manager who's a staff member, and the third arm is the health fare plus taxi improvement promoters tips plus this mobile text messaging intervention, and looking at the impact of these on healthcare access, primary care uptake, cancer screening, BMI reductions, and other healthcare outcomes. We also have projects that are really looking at taxi drivers' exposures and their higher risk for lung cancer because of their exposures. There's a very inexpensive intervention, a HEPA filter, which costs $125 a year and could potentially be a way to really decrease a driver's exposure, decreasing their cancer risk. So we're doing a pilot now where we have folks randomized to get a HEPA filter, then there's a waitlist control where they get one later, and then a peer control. And we're finding higher levels of black carbon and particulate matter in the drivers before the HEPA filter with a reduction after the HEPA filter. And this is another data into policy intervention. Given the preliminary results, the TLC is interested in a larger study, Taxi and Limousine Commission, and it could be that this HEPA filter intervention is an intervention for all of the drivers in the coming years, which would significantly decrease their risk. And a number of additional studies. We have a number of randomized controlled trials going on now, one around blood pressure, one around exercise, and then a colorectal cancer screening project. And again, all of these to translate the results into policy. So that gives you an idea of how we work out in the community. We bring the community together and the community-based organizations together to help us set the priorities and also develop and implement these studies and track outcomes. We like to translate these into policy, and at the patient level, really looking at the factors that impede good health outcomes and then trying to tick away at them one by one: language, socioeconomic status, the financial toxicity of cancer treatment, and then we do this all the way through into survivorship and also into palliative care. So I'd love to answer any questions if anybody has any questions, and thank you for this opportunity.